Today, we are thrilled to welcome Dr. Marguerite Duane, a board-certified family physician. She's the co-founder and executive director of Facts About Fertility, an organization dedicated to educating medical professionals and students about the scientific evidence supporting fertility awareness-based methods. She also serves as an adjunct associate professor at Georgetown and Duquesne University. Dr. Duane cares for patients via a direct primary care house calls-based practice entitled MD for Life. She previously worked as a medical director of the Catholic Charities Community Health Centers in D.C. and Maryland. Dr. Marguerite Duane currently serves as the CMA State Director for Washington, D.C. She has also served on the board of the American Academy of Family Physicians and the Family Medicine Education Consortium. Dr. Duane is trained as a Creighton, Fem, and Neofertility medical consultant and a Teen Star educator. She received her MD degree from the State University of New York at Stony Brook and completed her family medicine residency at Lancaster General Hospital in Pennsylvania. She received a Bachelor of Science with honors and a Master of Health Administration degree from Cornell University. In 2022, Dr. Duane completed a primary care research fellowship at the University of Utah, earning a Master of Science in Public Health. Dr. Duane is married to fellow family physician, Dr. Kenneth Lynn, and they are delighted to be parents of 4 beautiful children: Isaac Thomas, Eden Rose, Ellis John, and Gianna Marie Lynn. Welcome to the NFP Podcast, where we explore the empowering world of natural family planning. I'm Amy Smith. Join me and my co-host Emily Appledorn each week. Together, we're here to dive deep into the science, the stories, and the spirituality behind NFP. Every week, we push back against the free love culture and advocate for a culture of responsible love, where intentionality and respect are at the forefront of family planning. Join us as we discuss everything from the practicalities of charting and fertility awareness to the profound impact NFP can have on relationships and communities. Whether you're new to NFP or a seasoned pro, our podcast is your go-to resource for honest conversations, expert insights, and real-life experiences. So grab a friend, settle in, and get ready to be inspired. This is the NFP Podcast. Welcome back to the NFP Podcast. Today we are excited because we have a special guest with us. Full disclosure, she was my boss, actually still is my boss in a little bit of a capacity, but it's also a good friend. Dr. Marguerite Duane is with us, and we're excited to have a conversation with her medical expertise about natural family planning methods and the science behind them. So welcome, Marguerite. Thank you so much for being here.
Thanks so much for having me, Amy. I'm really looking forward to tonight's conversation.
So why don't we start out? I'm already aware of this story, and I think it's just a really great frame for our conversation by having you tell us a little bit about how you discovered NFP as a family medicine resident.
Sure. Yeah. So I was somebody who was always very passionate about women's health. Although I knew I always wanted to do family medicine. I had my call to become a doctor when I was just 8 years old, and I witnessed my baby sister being born at home, and that really just inspired my call to medicine. But it wasn't until I was in my family medicine residency that I actually first learned about female cycle charting and natural family planning and all that it is. I had gone to college and med school, and I was on OB call one night as a first-year resident. And I was doing what any good intern did on OB call. I was getting all of my postpartum patients ready for discharge. And as a resident, when you're getting your patients ready for discharge, one of the most important things we're instructed that we need to do is to prescribe birth control for them, because we want to make sure that they don't get pregnant again. And so I was sitting there writing prescriptions for the birth control pill or orders for Doppler shots and, whatever the patient wanted. And as I was doing that, one of my senior residents was with me, and she just started talking with me about let's talk about how birth control can affect women in the postpartum period, the side effects, how it might affect milk production, etc. And so we did. We started, talking through this. And at one point she said, well, did you know that there are some methods of family planning that actually have no medical side effects? I was like, what are you talking about? Like, every form of birth control has side effects, the birth control pill can suppress milk production. The depot shot can cause abnormal bleeding. I'm like, even condoms can cause like local sensitivity reaction. She's like, well, yeah. She's like, those were conventional forms. But when women use natural methods of family planning, they can identify when they're fertile and when they're not, and just modify their behavior. So they're not taking any drugs or using any devices. And so there are no medical side effects. I was like, what? What are you talking about? I've never heard of this. What do you mean natural methods of family planning? She's like, well, women, when they're cycling regularly, like they can learn to observe, different signs that indicate where they are in their cycle and whether or not they may be fertile. She's like, it's a little bit different for postpartum women because, they're often not cycling. But if a woman in the postpartum period is breastfeeding exclusively, she can use another natural method called the lactational amenorrhea method. And I was thinking to myself, I've never heard of any of these methods. And she's like, and the other good thing is like these methods appeal to people from all walks of life, like regardless of their faith, because they align, with people of different faiths. And so it's a great option to offer women, who might not want to use birth control for faith-based or even, personal or environmental reasons. And I was like, I never knew any of this. And as she's sharing this and I'm like thinking about this, I was just shocked. I was dumbfounded. I'm like, how do I not know this information? I mean, here I am, a medical doctor, passionate about women's health, wanting to do everything I can to really provide comprehensive women's health care. And I thought, why didn't I learn about this in medical school? Like this is seems very basic information. Like, and I know I didn't miss it in class because I went to all of my classes in medical school. And then I thought, well, why didn't I learn about this in college? Like, this would have been really good information for me personally when I was in college, because I think, like a lot of women, when I was in college, I was having issues with my cycle. I was dealing with some really painful periods, and I went to the student health center and they offered me the birth control pill. And I was like, well, I don't need birth control. Like, that's not what I'm here for. I'm like, I just got really debilitating cramps for a couple of days. And they're like, oh, no, it's okay. The birth control pill is fine. I'm like, but I have to take it every day? Like, that doesn't make sense. And they're like, oh, but it's good. And, and I was like, isn't there anything else? And they're like, no, this is what we recommend. And so being a college student, I didn't know much better. And so I started taking the pill. And, unfortunately, like so many women, I experienced like terrible side effects. I remember having severe hair loss, which was a little bit, distressing as a young college woman, and mood changes, which are pretty common. So I quickly got off of the pill, but was never offered anything else. And I kept thinking back. I'm like, well, why didn't I learn about this when I was 12 or 13 and I was first getting my period? Like, this would have been so useful. And so that shock quickly turned to anger. I was really angry. And I talked to so many women who experience a similar emotion, whether they're in medicine or just, interested in these for personal. They're like, why didn't anybody ever tell me about this? Why didn't I learn about this in medical school? And, I discovered it's because it's like the best kept secret. Like, most doctors don't know this information. Most of the faculty, that teach in medical schools are not familiar with this. In fact, when you worked with me initially through my work at Fax, and if you recall, one of the early research studies we did was we surveyed physicians who were either women's health directors or program directors at family medicine residency programs. And we asked them about their knowledge and familiarity with the different natural methods of family planning. And the overwhelming majority of them were not familiar with any of the modern methods. And if they did list a method they were familiar with, they put down the rhythm method, which I was like, that was developed a century ago. Like, medicine has advanced so much since then. And so when I think about those transformative times in my life, one, when I was 8 years old and saw my baby sister being born and decided I wanted to be a doctor. And then, nearly 20 years later, when I was on OB call and my senior resident, Dr. Pearl Huang, had the kindness to share the truth with me about the way the human body works and how our fertility works and how we can learn to monitor signs of fertility to better plan for our families, to truly plan for our families.
I think that, working with facts was such a kind of like a healing part of my NFP journey, because I held such resentment towards the medical professionals that, like my primary
Mm-hmm.
care, who just kept offering me the pill when I wasn't getting my period. And when I learned about all of this, I too, started crying and was in shock and then angry, because I thought that this information was being withheld from me.
Mm-hmm.
And then met you, got introduced to facts, started working in the medical professional world, and saw, oh, wow, it's actually not her fault. She genuinely did not have another option to give me. She did not know of anything else. She wasn't lying or withholding the truth. She didn't know. So I think that just speaks to what we always want to encourage women to do, which is to be self advocating
Mm-hmm.
for older women. And then if you're a mother, to be helping your daughter and to be a good advocate for her as well if she's having any type of reproductive health issues, to try to really attack root causes. So one of the things that you mentioned was just not learning about this in medical school. And would you say that specifically you didn't learn about like female biomarkers? Did you learn about cervical mucus, about basal body temperature? And then if you didn't, like, when and how did you finally come about learning all that? Kind of what was the next step in that journey?
Yeah, no, great question. And I will say, when I was in medical school, I did not learn about the biomarkers. What I learned about cervical mucus was that's often a sign of infection. And if a woman has cervical mucus or cervical discharge, you need to evaluate and treat her for a sexually transmitted disease. And even if your testing comes back negative, it may be a false negative. And so go ahead and treat anyway. And I still shudder to think about the women that I saw who came in with copious amounts of discharge, which I now recognize as likely fertile type mucus. And they tested negative, but we went ahead and treated them anyway because we just assumed, well, it must be an infection, because we did not learn there was such a thing as normal cervical fluid. I like to use the term cervical fluid. They're cervical fluid secretions as opposed to cervical mucus, because the term mucus just has a negative connotation as it is. And now, knowing everything I know and how critically important cervical fluid is for sperm survival and ultimately for fertility and for conception, I like to refer to cervical fluid as the elixir of life, because really without cervical fluid, sperm cannot survive in the woman's reproductive tract for more than 6 to 12 hours. But in the presence of cervical fluid, sperm can survive for up to 3 to 5 days, which is what allows conception to occur in most instances. But yeah, we didn't learn about cervical fluid. We didn't learn about basal body temperature. I was in medical school more than 20 years ago. At that point, the Marquette method was only in its infancy. We didn't learn about urinary hormones. It wasn't until that night on OB call when Dr. Huang, who was trained as a Creighton medical consultant, started talking to me, and she talked to me about cervical mucus. And, within a few months, I started learning more about that. And I was learning how to chart my own cycle, again, not from a family planning perspective, but just for my own health. And then a year or so later, when I was engaged and looking to get married, I decided to learn the symptothermal method. And that's when I really began to understand the role of basal body temperature. But it's learning about the biomarkers, those observable signs, cervical mucus, basal body temperature, urinary hormones, is not routinely taught in mainstream medical education. And I see that still today with the students that enroll in our FACS elective. I mean, as you know, FACS started after I had the opportunity to teach a small group of medical students at Georgetown about these methods. And what started with that small group of 9 students in 2010 has now evolved into a much larger organization where we teach over 200 medical students a year. And we just had our first group of students enroll. And again, they're like, we don't learn any of this in medical school. So 15 years later, this is still not a routine part of the medical education community. So back to your original point, like, yeah, your doctor wasn't holding out. She simply didn't know. The way that we're often trained in medicine to address any reproductive health issues in women, whether a woman is coming in with irregular cycles or painful periods or PMS symptoms, or abnormal bleeding or no period at all, it's like you put them on the pill. The pill is seen as the panacea for all that ails women. But what I've since discovered is the pill actually doesn't treat any of those conditions. It suppresses symptoms, gives women a regular withdrawal bleed, not a regular period, but a regular withdrawal bleed, but it never treats the root underlying cause of the issues. But that's the way most physicians, even still today, and not just physicians, but nurse practitioners, midwives, etc., that's the way that we're trained. We don't learn about these other, viable, real reproductive healthcare options.
Now, is that medical information, like kind of that dearth in knowledge, is it also present among the OBGYN community too?
Absolutely. Yeah. There was a study that came out in 2010, ironically, the same year that we started FACS, but it was a study of OBGYNs and family physicians, and it surveyed them about their knowledge and familiarity with modern fertility awareness-based methods, the Billings ovulation method, the symptothermal method, the standardase method. And what this study found was only 3 to 6% of OBGYNs and family physicians had any knowledge or familiarity with modern FABMs. So yes, it's pervasive throughout all of medicine, but in particular in the women's health specialties in OBGYN and in family medicine. And it's honestly due in large part due to the lack of education in medical schools, which, at FACS, we've looked at that too from a research perspective and have documented that as well, that there's a dearth in medical education on these topics.
Thank you for specifically clarifying, though, that OBGYNs are also lacking in this information. I've heard from women when I talk, kind of in broad terms about this and that their doctor is probably not informed. They'll say, well, my OBGYN knows, though. To which I kind of, and then they'll walk away and I'm like, wait, no, they actually don't either. So
they don't. They don't. And it's unfortunate,
It is. I mean, that's their area of expertise.
Right. And it's a disservice to them because they don't know. They can't do nearly as much to help their patients. And I believe doctors go into medicine because they truly do want to help their patients. And
absolutely.
So FACS, we're really focused on helping them to expand their toolbox so that they can really enhance, the care that they provide patients.
And so if you are a patient who has a really great relationship with their medical professional, OB, family medicine, whatever it is, and you feel like they might not be knowledgeable, I'm going to link again, although we've mentioned FACS many times, I'll link to the website again, and you can go on there and get some information to share with your doctor and direct them to that website. They can get CEU, right, presentations. They can attend webinars. They can learn a lot. They can kind of catch up on lost information and make up for lost time. So do you want to say anything about that?
One thing I would say is we have a great article that I published with a couple of my mentors back in 2022. It's called Fertility Awareness-Based Methods for Women's Health and Family Planning. And it's a fairly comprehensive review of natural or fertility awareness-based methods, their applications in women's health, and their effectiveness for family planning, both for preventing pregnancy and achieving pregnancy. There's over 100 peer-reviewed citations. So it's a well-referenced scientific article. It's available for free. If you click on our website and click on research, it's the first article. I encourage your listeners, download that article, print it out, bring it with you to your next appointment with your doctor or your midwife and share with them and say like, hey, I found this. Are you familiar with this? And then link back to our website because we offer online continuing medical education, online and in-person conferences. Our next online conference is October 18th and 19th. So we're constantly looking for ways to make it much easier for the medical community to access this information, to expand their knowledge, educate themselves, so they in turn can educate and really empower women and men to care for their reproductive health.
That's awesome. And I'll make it even easier. I'll just link right to that article in the show notes too, right from the FACS website.
Awesome.
So, okay. So one of the things you mentioned were the biomarkers, right? So we've got urinary metabolites. We've talked about all these before, but cervical fluid. Now, I say cervical mucus because when I'm explaining it to people, people are often familiar with mucus as a biomarker from other parts of their body. And I always refer to like the mucus in your nose, right? When you're blowing your nose, your kid's nose, what color is it? What does it look like? And that can tell you what's happening internally. But yeah, cervical fluid, cervical mucus, just so, if people are hearing us use these terms interchangeably, we're both talking about the same thing.
Yeah,
Um,
exactly.
Right. So those are the biomarkers. Now we know that the medical professionals are not as well trained in understanding these biomarkers and how to interpret what is being seen. So fertility awareness-based methods, natural family planning methods, have been developed by physicians and scientists. Basically, what they've done is they've studied, I'm going to just prep this, okay, and then you jump in, Marguerite, is they've studied these biomarkers and the patterns that women observe of these biomarkers, and they've taken that to develop these methods. So
Mm-hmm.
from our knowledge, from the science of biomarkers, different methods have evolved. Like they've kind of shot
Right.
out from this basic biological just reality of what the female body produces during her menstrual cycle. Different methods have come out of that. And then they've done research when they've developed this method to see, okay, now I've put these protocols in place, have intercourse here, don't have intercourse here. This is what this discharge means. This is what this discharge, this is what this observation means, and this observation means. And then they run a study and people use it and they see, okay, how effective was I or is this method at monitoring the cycle and then at helping people interpret those signs. Do you think that's kind of a pretty good summary of how those came
Yeah,
about?
I think that's a great summary. And I think what's important to know is that the scientists are still studying these biomarkers and ways to better track them. And when I teach my medical students and others health professional students, I explain to them that these observable physical signs, these external observations that a woman can observe, her cervical mucus, her basal body temperature, her urinary hormones, reflect the internal hormonal changes that she experiences on a day-to-day basis. So I tell them the chart of the female cycle where women write down their observations provides a daily diary of a woman's hormonal health. And it's absolutely amazing. I mean, if we just look at cervical fluid or cervical mucus alone, there are different types of cervical mucus that are produced based on the hormones that the woman is experiencing. So as you know, well, let me just start with this. We often, the most observable sign that every woman can typically identify is her period or her menstrual bleeding, right? And we often use the menses to mark the beginning of the cycle. But when I talk to students, I'm like, why do you think we call the menses the period? What is a period? And we talk about the fact that the period marks the end. It marks the end of the sentence. And in women, it actually marks the end of the ovulatory cycle. So in fact, the menses, the period, isn't the beginning of the cycle. It's actually the end. And so technically a woman's cycle starts after her period ends. And in the beginning, when her hormone levels are still low, she won't notice any mucus. But as her estradiol is beginning to rise, the estradiol hormone acts on the glandular cells of the cervix to produce what we call type E mucus. This is mucus that's produced under the influence of estradiol. And this type E mucus can actually be divided into further subtypes. And this type E mucus is produced typically over a 3 to 5 day window of time, sometimes a little more, sometimes a little bit less. And it changes, it may be, white or cloudy initially. There may be just a little bit, but as her estradiol continues to rise, she tends to produce more of the cervical fluid secretion, and they tend to become more clear, stretchy even. I'll often describe it as like raw egg white. So most of us, we've all made an egg in our lifetime. You crack open an egg, you see as the egg comes out, the clear egg white. That's what this fertile cervical type mucus will look like. And this is a very clear indication that a woman is entering into her fertile window, meaning this is the time when she could potentially get pregnant. This is such empowering information and literally can be a matter of life or death, in the sense that I like to share the story. I was taking care of this couple in Inner City, DC, and they'd come to me because they were trying to get pregnant, and they've been trying for over a year. So they technically met the definition of infertility. And in taking her history, the wife thought there was something wrong with her because her husband had a child from a previous relationship. And she shared with me that she she got what she thought was like a recurring infection. And what she described was this discharge that she would get almost every month. It would usually last for a few days. Sometimes there was a little mucus, sometimes there was a lot of mucus. But whenever she noticed this discharge or observed this mucus, she would avoid having sex with her husband because she didn't want to give him whatever it was that she had, presuming that she had some sort of an infection. And as she's describing these symptoms, and I'm taking a detailed history, I'm thinking to myself, you were describing your normal, healthy, fertile cervical mucus. And so I, did some testing and, ruled out any sort of infection and explained to her, like, what you're describing is the mucus that your body produces when you are entering your fertile window. And by not having sex with your husband every month when you have this mucus, you're actually avoiding having sex during the time when you can get pregnant. I said, humor me. Next month when you have this mucus, have sex. Like the only thing you're going to give your husband potentially is a baby. And sure enough, they got pregnant 2 months later and came back to me and thought I was a miracle worker. And I'm like, all I really did was explain to you how your body works. But it was so incredibly empowering. And, we see it not only with cervical mucus. And like I said, cervical mucus is, one consistency under the influence of estradiol, and under the influence of progesterone, it will change to a different consistency. And the mucus produced under the influence of progesterone is really important too, and it plays a critical role in protecting and developing embryos. So cervical fluid or cervical mucus is so critically important for fertility. But basal body temperature is also very helpful when it comes to charting with fertility awareness-based methods. When women track their basal body temperature, again, this external sign reflects an internal hormonal change. And in the case of basal body temperature, it reflects the change in progesterone. So progesterone is the hormone that's produced after ovulation. When the follicle is releases the egg, the remnant follicle forms the corpus luteum and begins to produce progesterone. And as the progesterone rises, so does the woman's basal body temperature. And with this rise of the basal body temperature and this, consistent elevation of basal body temperature, this gives a clear indication to a couple that they're no longer fertile. So if they're using a natural method to prevent pregnancy, it really helps give confirmation that you can have sex all day, every day for the next 10 or 12 days, and you're simply not going to get pregnant. So that can be incredibly helpful for couples. But for couples that are trying to get pregnant, it can also be really helpful, because when couples are trying to get pregnant and the basal body temperature rises, if it stays elevated for more than 16 days, that's a clear indication that the woman is pregnant until proven otherwise. So that's oftentimes people can pinpoint the timing of conception based on the length of the elevation of their basal body temperature. And then urinary hormones are the third biomarker, and these are like the new kid on the block. They're really great. And so with urinary hormones, initially with the Clear Blue fertility monitor that is used in the Marquette method, that detects estradiol metabolites and luteinizing hormone. So again, these are both hormones that are indicative of the fertile window and when ovulation is about to occur. So it can be very helpful information. But now there are newer monitors and newer devices and newer test strips that women can use to check other hormones like progesterone. For example, there's the Prove test strips, which not only can check progesterone, but they've got Prove Complete, which can check FSH hormone, estradiol, progesterone, and luteinizing hormone. So all of this information can, again, give really detailed information, not only to the woman, but also to the doctor, especially if you have doctors that are trained to read the female cycle chart. And in fact, that's one of the first lessons our medical students learn is how to read the female cycle chart. And we teach them how to do it in a systematic, standardized way so they can use the information from your daily diary of your hormonal health to actually interpret and develop a more appropriate diagnostic and treatment plan based on more accurate information about your hormones that are reflected in the biomarkers that women can learn to chart.
So, Dr. Duane, we kind of went through all of the biomarkers, the cervical fluid and basal body temperature and the urinary metabolites. And our understanding of the current methods that are used for natural family planning is that scientists, doctors have taken the foundational understanding of these biomarkers, like women's physiology, and they've applied this understanding and created kind of a systematic way of monitoring and logging and interpreting all of this information. And then they have studied that and found, okay, if you have intercourse during this time, you will likely achieve a pregnancy. If you don't have intercourse during this time, you will avoid a pregnancy. And so anyway, different methods have kind of come out by you, but they all use a conglomeration of these biological markers. So what I'd love for you to do, if you could, is kind of briefly just go over what the different methods are that are available for women, and maybe also touch on what would be the best season of life that you would be in to use that method. If there is a specific good season or better season for a specific method.
A great question. So as you noted, modern fertility awareness-based methods can use 1, 2, or more biomarkers to help women identify what we refer to as their fertile window. So that is that period of time when they could potentially get pregnant. And it's really important to note that despite what our society may tell us, women actually are not fertile all the time. There's a very narrow window of time in which they're actually capable of conceiving. And that window of time is really around 3 to 6 days. And when women learn to observe their biomarkers, they can identify that window of time with the different types of fertility awareness-based methods. And there's really 5 main types. Women will observe 1 or more biomarkers. So the first type that I like to talk about are the cervical mucus or cervical fluid methods. And I like to talk about these first because these were really the first of the modern methods developed, beginning with the Billings ovulation method. So the Billings ovulation method was developed in the early 1960s by doctors John and Evelyn Billings. And with the Billings method, the woman learned to observe and chart the sensation that she feels at the vulvar area during the day. So she's really taught to just be mindful and to pay attention to the sensations that she's experiencing in the genital area. And at the end of the day, she'll record in her own words what she notices. And again, she's encouraged to note sensation, but they are also able to record what they observe based on visual inspection, although it's not a required part of the Billings ovulation method. With the Billings ovulation method, women learn to observe their basic infertile pattern, which for many women may just be days of consistent dryness, but for others it may be, a very consistent non-fertile type mucus type pattern. And they learn to identify the change to their more fertile pattern, again, to identify that fertile window. The second cervical mucus or cervical fluid method is the Creighton model. And this method was developed by Dr. Thomas Hilgers in the early 1970s. And Dr. Hilgers is an OBGYN who really, as in his own words, said he was responding to the call of Pope Paul VI in Humanae Vitae to men of science to do the research to help couples learn to naturally regulate their fertility. And with the Creighton method, similar to the Billings method, women learn to observe their cervical fluid secretions or their cervical mucus. The difference with Creighton is not only are women taught to observe the sensation, but they are also taught to observe and finger test the cervical mucus or cervical fluid to see how much it stretches. So with Creighton, they use the acronym SOFT. That is, women will pay attention to sensation, observe for any cervical fluid or cervical mucus, and then if they note cervical mucus, they'll finger test it. With the Creighton model, women use a very specific way in which they record their observations, and this is called the vaginal discharge recording system. The advantage of this is that for physicians or healthcare professionals like myself who are trained as Creighton medical consultants, when I see a Creighton chart and I see the codes that women have written underneath their the days to identify their cervical observations, it becomes much easier for me to interpret because it's a more objective recording of her signs. So with the Billings and ovulation method, both of which only require observation of cervical mucus, women are able to identify that potential window of fertility. So these methods can be used not only to help couples prevent pregnancy, but also to help couples achieve pregnancy, which I think is beautiful because it highlights that natural or fertility awareness-based methods are true methods of family planning because people can use to plan them to avoid or to achieve pregnancy. There's one other cervical mucus only method that is a much simpler method, and this is called the 2-day method. And it was developed at the Georgetown Institute for Reproductive Health, primarily for use in third world countries where they have much more limited access to family planning methods. With the 2-day method, women will check to see if they have cervical fluid secretions, whether or not they were present today or yesterday. If a woman had cervical fluid secretions today or yesterday, she would consider herself potentially fertile, and if she's trying to avoid pregnancy, would avoid sexual relations during that time. This method is a great method because it's really easy to teach and use, but it does have its limitations. If a woman has a chronic discharge that may, according to Billings, be classified as a basic infertile pattern, but if she's having mucus, she would not be able to use the 2-day method. The other limitation is it's not as effective, and it really does not help women to identify that fertile window. So it's not as effective to use for achieving pregnancy. So those are the cervical mucus only methods. The next methods include those that involve basal body temperature. So there are basal body temperature only methods. With BBT only methods, with these methods, women use a calendar calculation to identify the beginning of their fertile window, and they use the rise in the basal body temperature, which again, if you recall, the rise in the basal body temperature reflects the rise in progesterone, and the rise in progesterone can only occur after ovulation. So with these methods, they use calendar calculation and change in basal body temperature to identify the beginning and the end of the fertile window. The other type involving the basal body temperature is the symptothermal method. With the symptothermal method, women will use both calendar calculation and cervical mucus observations to identify the beginning of the fertile window. And then they'll use the cervical fluid observations and the basal body temperature rise to identify the end of the fertile window. The symptothermal method is regularly taught throughout the United States and really around the world. The most common methods, ways in which it's taught is through Couple-to-Couple League and SymptoPro. And in Germany, they developed the method Sensaplan, and this is the method that probably has the highest quality studies for effectiveness of any of the natural methods of family planning. And it is very effective both with typical and correct use. The next type of methods I want to talk about are your symptohormonal methods. Again, sympto refers to the symptom of the cervical mucus, and hormonal refers to the urinary hormone observations. So again, women will use observations of cervical fluid in combination with changes in urinary hormones to identify the beginning of her fertile window, and then using cervical fluid observations and urinary hormone observations to identify the end of the fertile window. The most commonly used symptohormonal method is the Marquette model. And with the Marquette model, women will use the Clear Blue Fertility Monitor to detect their urinary hormones. The Clear Blue Fertility Monitor is designed to detect the rise in estrogen or estradiol metabolites that happens as a woman is beginning to enter her fertile window. The monitor will also detect the LH surge, which typically happens shortly before ovulation. So again, this is another good marker that ovulation is about to happen. So again, with the symptothermal and the symptohormonal methods, both of these methods are what we call cross-check methods because they use two observations of biomarkers to be able to cross-check identifying the beginning and the end of the fertile window. The next type of fertility awareness-based methods are methods that actually only use a calendar calculation or the days of the cycle to determine the fertile window. The rhythm method, which is the method still most people are probably familiar with, which, as we talked about earlier, was developed more than 100 years ago, was actually the first calendar-based method. Most people today, if you ask them how the calendar rhythm method works, they don't actually understand the formulas used with the rhythm method. And most people who say they're using rhythm aren't really. The rhythm method has not been extensively studied in modern research studies, so it's hard to speak to the effectiveness of the rhythm method. However, there is a calendar-based method called the standard days method, which has been extensively studied. The standard days method was also developed by the Georgetown Institute for Reproductive Health. And with this method, what they determined in women who have regular cycles that last between 26 to 32 days long, they have identified a fixed window of potential fertility. And that is between days and 8 to 19, women with regular cycles lasting between 26 to 32 days would consider themselves fertile for that 12-day window of time, beginning on day 8 of their cycle through day 19 of their cycle. Again, the World Health Organization considers this a modern method because the method has been well studied and found to be effective in well-designed research studies. The final modern fertility awareness-based method is personally probably my favorite method, and this is the lactational amenorrhea method. The lactational amenorrhea method, or LAM for short, is a method that may only be used by postpartum women who are nearly or fully breastfeeding. So in order to use LAM, a woman must not have had a return of her menstrual bleeding since birth. Again, she must be breastfeeding fully or nearly fully, and the baby must be less than 6 months of age. With LAM, the effectiveness rates can also be very, very high. Now, to answer your question, during which phase of life might one method may be better than another, it really is going to depend from woman to woman. Typically, though, if we think of adolescence, if I'm teaching young girls how to chart their cycle, because young girls are primarily using their observations for health monitoring purposes and not necessarily because they're struggling with significant illnesses or, dealing with infertility, I find that the Billings ovulation method tends to work best in the adolescent population. And in fact, there's a program called Teen Star, which stands for Sexual Teaching in the Context of Adult Responsibility. And this program specifically teaches young girls about their changing body and how to observe the signs of their cycle using the Billings ovulation method. For me personally, when I first started using a method for my own health monitoring purposes, I chose to use a cervical mucus only method. However, as I was preparing for my marriage and I was engaged and I was starting to think about what I wanted to use after I was married, I chose to use the symptothermal method because I liked the idea of having that cross check. There's a real nice advantage to it. But you know me well enough, Amy Lynn, to know that I am not a morning person. And so taking my temperature every morning sometimes was a bit of a challenge. And so I found that symptothermal wasn't necessarily the best for me. But for people that do like that cross check and have fairly regular schedules, symptothermal method can be really, really effective. I've already alluded to the fact that, for women that are struggling to get pregnant, if they're having underlying health issues, the Creighton model is a really, really beneficial method because of the detail with which women learn to observe and record their cervical mucus observations. So oftentimes I will recommend that women chart with Creighton if we're trying to work at getting at underlying reproductive health issues or underlying causes of infertility. This Marquette method, one of the other cross-check methods, I have found to be very effective and very helpful in women that like a cross-check, but also in women in the postpartum period. Perhaps they're more than 6 months postpartum and the lactation amenorrhea method is no longer an option for them, but they may not have return of their cycles yet. And so the Marquette method I find to be really effective in postpartum women because they have a specific postpartum protocol that women can use to help identify their fertility. The standard days method, I think, is a great method, again, in women who have really, really regular cycles, women that don't want to think about checking their mucus. It can be really, really helpful. I also actually we'll discuss the standard days method. I'm often invited to give talks to a wide variety of audiences, medical audiences and general audiences. And occasionally I'm invited to speak to priests and deacons and seminarians. And, they often confront me with the question that how do they counsel couples who want to, abide by the church's teachings in terms of their marital relations, but their doctor has the woman on birth control for health reasons. And as I explained to the priests, when a woman is on hormonal birth control, she does by default have quote unquote regular cycles, although she's not actually having a regular menstrual bleed, she's having a regular withdrawal bleed, but they are having cycles that range between 26 to 32 days. So if the couple wants to be sure that they're practicing in accordance, with their faith and not risking pregnancy at all, they can actually follow the rules of the standard days method and avoid sexual relations between days 8 to 19. So at FACS, we talk about there are many different methods, and there are methods for many different situations. Some people really like the technology and the ability to track via apps. Some of the methods have more apps available to them than others. Some people like to learn online. Some methods have more teachers that are available online. Some people have very low health literacy. I worked at a community health center in Washington, D.C., where we served an almost entirely uninsured, non-English speaking, low health literacy population. And again, for us, the mucus-only methods were really, really helpful in that regard. So the reality is there are a number of methods. All have good evidence to support their effectiveness. And regardless of where you are in your reproductive life journey, there will likely be a method that will work best for you. At FACS, we have a presentation called The Facts About Fertility Explained, and it's available as an on-demand webinar. Anybody can register to watch it, but we talk about the different signs, the different methods, and the factors that you may want to consider in choosing a method that would work best for you.
Oh, perfect. I'll link to that webinar then in our show notes. So you touched a little bit on, the effectiveness of these different methods. Thank you. That was an awesome overview, by the way. But you talked a little bit about the effectiveness of these different methods for avoiding and achieving. Maybe you can give a little bit of number breakdown. And you mentioned something called typical use versus, correct use. So maybe flesh that out a little bit. And in that, if you could also touch on, I saw a recent blog post from you guys at FACS highlighted a study looking at the importance of the motivation of the users of methods.
Mm-hmm.
And that's something Emily and I just did a whole episode on, the effectiveness of NFP, and we both had a little bit of a rift on, things that we've heard over the years as NFP teachers, of people sharing their experiences of how effective or ineffective they believe NFP to be, and yet they weren't necessarily practicing the method as it was supposed to be practiced, right? Okay. Or you hear third party, well, I know, my friend, Karen used NFP and she had 4 babies and they didn't want to have any babies. And it's like, well, did you ask Karen, what method specifically was she using? Did she just make up her own thing and calls it NFP? Did she work with a trained teacher? Did she just take one class and then figure it out on her own? Or was she following something to the T and it was wrong every time? Or are you asking to flesh it out? So we just really were encouraging our listeners to be curious when you hear secondhand, oh, so-and-so is using NFP. What do they mean by that? Ask some more questions. Don't necessarily judge the effectiveness of a method by hearsay. So maybe you can touch on those things a little bit, the actual effectiveness rates of some methods, typical versus correct use. And then more importantly, kind of hone in on the importance of motivation of the user and how that relays into the application and the effectiveness.
Yeah, absolutely. You raised some really, really important points. And when I teach people about the effectiveness rates or the effectiveness of natural or fertility awareness-based methods, I always highlight that the effectiveness of a method really depends on 3 factors. 1, that you learn the method from trained instructors or the way the method was designed to be taught. To date, almost all of the methods, in terms of their effectiveness studies, they're based on when women and men learn how to chart from trained instructors. One of the benefits and challenges is that there are so many fertility tracking apps out there, and yet a lot of women will rely on the app and not actually learn how to chart from an instructor. And that's a big mistake because they're not going to learn the ins and outs of the method and the guidelines for use. So factor number one that's important for effectiveness is learning from a trained instructor. Factor number two is having partner support. The reality is that fertility awareness-based methods as a family planning method recognize the fact that it takes two to plan a family, right? It takes two to have a baby and it takes two not to have a baby. And in order to use FABMs effectively, a woman and a man need to be supportive of one another. And that can be a challenge when like people's levels of motivation are different or libidos are different or desire for sexual relations are different. So if you don't have a partner that's supportive and, you have sex more than you feel comfortable, or when you might be concerned that's a little bit on the edge of your window of fertility, you do run the risk of an unintended pregnancy. So learning from a trained instructor and having a supportive partner. And then the third factor that's crucial for effectiveness is motivation. When I was first in medical school and learning about effectiveness of family planning methods, they kind of make it like a black and white decision. It's like either you want to be pregnant or you don't want to be pregnant. And the reality is it's not that black and white. If you ask people like their desire for pregnancy, it really falls across the spectrum, with 0 being, I absolutely don't want to be pregnant and I would do anything in my power to not become pregnant, including ending an early pregnancy, because that's how strongly I feel about not wanting to be pregnant. And then you have people on the other end of the spectrum that are 10, they're like, I absolutely want to be pregnant. I'm going to do everything in my power to become pregnant. Most people, I like to refer as, they live in the mushy middle, like kind of like between a 3 and a 7. Like, I really don't want to be pregnant, but it isn't the worst thing in the world. And so that's a really important factor to consider, because if you're not as committed, dedicated to like, I can't get pregnant, you may be less motivated to follow the rules of the method, i.e. avoiding sexual relations during that fertile window, if you're not as concerned. So I'll talk a little bit about the motivation in a bit, but let me talk about the effectiveness rates. There are different ways in which we classify effectiveness rates. And it's funny because I'm just working on a presentation for this that I'll be giving next week. So probably the most informative rate is what we refer to as the typical use pregnancy rate. And to calculate this, we count all pregnancies that occur when a couple's intention is to avoid pregnancy. So that is, do they want to avoid pregnancy and did they get pregnant? That's our numerator. And we divide it by all the cycles in which they were intending to avoid. So that means both with correct or typical use. So sometimes people don't always use the method correctly. They may not always follow the rules. They may not always record all the observations, and that's part of the denominator. Whereas with correct use, this refers to the number of pregnancies that occur when couples are using the method correctly to avoid, divided by all of the cycles in which they had correct use of the method. So correct use rates tend to be much, much higher, 98, 99%, whereas typical use rates can really vary much more, typically ranging from 86 to 98%. And it really reflects the importance of motivation. So in terms of the effectiveness rates, and I often tell people, if you look up the effectiveness rates for the methods, you're going to find that they're going to vary a great deal. But I also caution people that you can't compare the effectiveness rates apples to apples, because the studies were not all done the same way. They were not all done in the same population. They didn't classify pregnancy intentions in the same way. And so you can't really compare it apples to apples. So based on the highest quality studies, for example, the Billings ovulation method has an unintended pregnancy of 10.5 unintended pregnancies per 100 women years in the highest quality study that was done in India in a population with a predominantly low literacy, low educated population. Over 80% had less than a fifth grade population. And in this study, they asked women at the beginning of the study whether or not their intention was to avoid pregnancy or not. Now, they didn't go back and ask the women in 3 months or 6 months or 9 months. And I don't know about you, Amy Lynn, but I change my mind more than once a year, right? So it is important that we ask women their intention. But if a woman started in the study with an intention to avoid and 6 months later she changed her mind and they started trying to achieve, if they got pregnant, it was still classified as an unintended pregnancy, right?
Right. It would have been more prudent to ask them at the beginning of every cycle
Exactly.
what your intention was.
And that's actually what they did in the symptothermal study. The highest quality symptothermal study done to date was done in Germany. This, again, a very different population. Over half had at least elementary school. 20% had more than a high school education. So a much better educated population. But also they asked the couples at the beginning of each cycle what was their intention. And at the beginning of the study, they may have intended to avoid, but 6 months in, if they said, no, we want to achieve, then they were dropped from the study. So if they got pregnant, that pregnancy then didn't count as an unintended pregnancy. And so based on that study, the symptothermal method has a 98% effectiveness rate, or 2 unintended pregnancies per 100 women years. So again, that may make it seem like, symptothermal is much more effective, but not necessarily, right? Again, it depends on how good you are going to be at using the method. And as I mentioned earlier, like the symptothermal method, I was terrible at it. I was actually much better at using a cervical mucus only method more accurately. So,
well, that also speaks to the importance of having researchers in their study design. Like,
exactly.
it would have been nothing to do with like the education level of the different populations either. It could have just been like, you guys should have been asking at the beginning of every cycle what your intention is, because
Exactly.
it doesn't stay the same for 9 months necessarily.
Yeah, exactly. And in fairness to the Billings folks, I mean, they did this study more than 20 years ago. And part of the challenge is we need more research, right? We need more studies looking at the effect.
Something's better than nothing.
Updated studies, yeah. But as you know, I mean, this is partly why I took this new position at Duquesne University as the director of the Center for Fertility Awareness, Education, and Research, so that we can, do more of these studies. But the effectiveness, bottom line, the effectiveness rate of modern fertility awareness-based methods with correct use, they're more than 95% effective, with some as high as 99% effective. But the reality is none of us are perfect. We're not going to do things correctly. So we really need to look at the typical use effectiveness rates. And with typical use, the effectiveness rates range anywhere from 86 to 98% effective. That is, they have 2 to 4 unintended pregnancies per 100 women years. That being said, I always like to tell people, it's not a zero-sum game. You're not 98% pregnant. Like, you're either pregnant or you're not. And so while it's helpful to have a general sense as to the effectiveness numbers, you also have to look for yourself, how seriously do I need to avoid pregnancy? Now, you just mentioned the blog that we just published on our FACS website, and it was it was a summary of a research study that was performed by Dr. Richard Farring, who developed the Marquette method. And in this study, they specifically looked at the motivation of couples and the effectiveness rates of the method. And what they found, and this really honestly did not surprise me, is that couples in which both partners were highly motivated to avoid pregnancy, they were much more likely to use an FABM effectively. Specifically, they found that in the high motivation group, the 12-month unintended pregnancy rate was 8 per 100 women years, so about 92% effective. However, in the low motivation group, those that were like, maybe want to avoid it, not really trying very hard at it, the 12-month pregnancy rate was 75 per 100 women years. So clearly a significant difference. So it just goes to show you, if your motivation is low, probably not going to use it as effectively. And again, I mean, I can speak to that from my own personal experience. Like, there was a time in my life when my husband and I had a very, very serious reason to avoid pregnancy, and we were very diligent in our use of the methods, and we were able to successfully avoid pregnancy for close to 4 years. And then when we were less motivated and more open, we weren't done necessarily with having children. We weren't actively trying, but we were just generally open. It was quote unquote less effective, although I thought it was very effective because I had another child who's amazing. So, and that's the other thing when it comes to looking at effectiveness rates. When you're doing effectiveness studies and you have women who are participating that have never had children but are open to having children, they may not be as motivated as the person who's already had 3, 4, 5, 8 children. She's like, I'm done. They may be more motivated. So there's so many factors to consider. But, for the individual, for the couple, I tell them, find the method that's going to work best for you. Learn the method from a trained instructor. Make sure you and your partner are on the same page and have those conversations. And that's the beauty of using these methods, is they foster these conversations. Like, where are we with our family? Like, are we ready for more? Do we think we can handle another? Do we really need to avoid because, my husband's taking on a new class that he has to teach, or he's going to be traveling more for work and maybe we need to postpone. And then, really assess that motivation. When it gets to apps, and I don't know if you want to talk about this in more detail.
Yeah, you can go for it. That was going to be another question, was what is kind of the latest femtech
I was
out
just going
there?
to touch briefly before we get to that. Like, there have been a couple of apps that have looked at the effectiveness of the app for avoiding pregnancy. But in general, I tell women, if you're using an app is a great tool to facilitate tracking your cycle. But you should not let your app tell you when you're fertile or when you're not. I tell women, you are smart. You are smarter than your smartphone. So don't let your phone tell you when you're fertile or when you're not. Learn how to track your cycle from a trained instructor. Use an app to track the signs, but you should learn how to interpret those observations. And this does segue into apps. As you know, Amy Lynn, one of the studies that Fax did now more than almost a decade ago, it's one we really need to repeat and update, is we looked at fertility tracking apps. And we looked at those that were being marketed to women and couples for the purposes of preventing pregnancy. And at the time, there were nearly 100 apps on the market that were being marketed to avoid pregnancy. But when we went to look at the effectiveness, we ended up having to eliminate over half of the apps from our study because they weren't actually even based on one of the modern evidence-based natural methods of family planning. So we ended up ranking or reviewing and rating under 50 apps. And of those, there were only 10 that we could highly recommend as potentially being effective tools for tracking the cycle. And I'll share the link with you so you can share it with your listeners. We do have a link to our summary sheet where we highlight the top methods the top apps that we would recommend. Again, I say that with a word of caution because, the study's now nearly a decade old and there are newer apps. It seems every month there's a new app on the market. But the nice thing about apps is that you can use them not just for pregnancy prevention, but a lot of women like to use it for fertility monitoring or health monitoring. And apps that might be really good for health monitoring may not be great for pregnancy prevention. And so when it comes to deciding what app to use, it really depends on what your goal is. One of my favorite apps that I think has pretty broad appeal is an app called Read Your Body. And I really like the Read Your Body app for a couple of reasons. One, it's very customizable in that you can select the things that you want to track. You can select the biomarkers that you want to track. You can select signs or symptoms that you want to track. You can select if you want to track things like your diet. So it's really nice because it allows you to customize the fields that you're going to keep track of. The other thing I really like about the Read Your Body app is that the data lives on your phone. It does not live in the iCloud, which means you own your data and it's not out there for the universe. And that's a real issue because when we did our app study, one of the things that caused apps to rate lowly was, the lack of data privacy or security. And this is a real issue when it comes to fertility tracking. It's such a big issue that this is actually the theme of our kickoff presentation for our FACS virtual conference on October 18th. We have Dr. Thomas Bouchard, who's a family physician and a Marquette-trained instructor, who's going to be speaking about fertility tracking devices and fertility apps. Dr. Bouchard's really an expert in the field because he's actually done a lot, not only with apps, but with the newer tools that are being used to help monitor hormones. So we talked about the Clear Blue Fertility Monitor, which is incorporated into the Marquette method for tracking estradiol metabolites and LH hormones, but there are newer devices now as well. There's the Prove test strips. Originally, Prove was developed to check progesterone levels in the urine to prove that you have ovulated, hence the name Prove. But now there's a Prove Complete, which allows women to track LH, estradiol, FSH, and progesterone. So it includes lots. There are other newer devices called Aneto and Mira, and these are all monitors that also will allow women to track more urinary hormones. The jury's still out in terms of like the effectiveness. Again, Dr. Bouchard's one of the leading researchers looking at that, as well as my colleague, Teresa Stujanski, who works with me at Duquesne. She's the director of research for our new Center on Fertility Awareness. But we do definitely need more research in this area. In terms of other apps that I like I said, I really like the Read Your Body app. I also like the Chart Neo app, and the Chart Neo app was developed by Dr. Phil Boyle and his colleague AJ, who actually created the app, and they designed it to be used in conjunction with the Neo Fertility method. Now, I don't even know if I've mentioned Neo Fertility yet, or FEM. FEM stands for Fertility Education and Medical Management. Both Neo Fertility and FEM are methods with medical management protocols. So I'm trained not only as a Creighton Napper medical consultant, but also as a neo-fertility medical consultant and a FEM medical consultant. So I'm trained in all three medical approaches that really allow me to provide much more comprehensive and restorative reproductive health care to women and to men. And so with neo-fertility, we use the Chart Neo app. And again, it allows us to track all of the biomarkers as well as medications, signs and symptoms, so we can see how that correlates with the female cycle. So I really do like the Chart Neo app. FEM also has its own app, and it's relatively easy to use as well. And I think it's one of the free apps, so I like that as well. There's also the new Peak Day app, which I just downloaded a couple of weeks ago on my phone. One of my patients has downloaded it, and apparently we'll be able to share data for me as her physician to be able to look at her data as a patient. And this app also has the ability to track more signs. This was developed by the folks at the Fertility Science Institute and Couple to Couple League, again, to be able to track more signs. So the challenge is there are so many apps out there. There are some I don't recommend, some of the more popular ones, in fact. Flow, I've got some serious concerns with that app. It just is as one example. And I do encourage users, if you're using an app, to check what do they do with your data, and is your data private and is it secure? So I just encourage people to really look at that when they're trying to do an app. Now, I will mention again Natural Cycles, because Natural Cycles is the one app that has done a couple of different studies to look at the effectiveness of the app itself. And the method is effective. I think their research shows they have a unintended pregnancy rate of 7 unintended pregnancies per 100 women years with typical use. But what's important to note is with Natural Cycles, typical use can include the use of condoms during the fertile window. So that's just another point to note there. But yeah, a lot of apps on the market, a lot of fertility tracking devices, yet a lot of it is still very much the Wild West in terms of what do these mean really? How effective are they? This is why we need so much more research. So I'm grateful to my colleagues like Dr. Thomas Bouchard and Teresa Stujanski and Richard Faring, and the work that they and others like Amy Beckley are doing on this in this particular area.
That was awesome. Yeah, I wasn't aware of all those different apps that are available now since last time I looked into it. So That's great. Great resources.
I honestly wish, like, one of my goals is if FACS could raise the funding, we really do need to redo some of these app studies. A lot of the studies of apps are done by the apps themselves. And so there's a huge
Right.
conflict of interest, which is why you really do need like a third party, like neutral organization like FACS or Duquesne that can then do these research studies. But it takes funding, and that's always the challenge.
Right. Now, in one of the studies you just mentioned about the app and the effectiveness rate was influenced by people potentially, right, using a condom during the fertile window. And this is something I just wanted to bring up briefly with you, was to say, we promote abstinence during the fertile window. Emily and I talk about that a lot because we also talk about the act of intercourse and that it images who God is, right? And so we can't, that's why we can't mess with the act, because it is imaging who God is and we can't change who God is. But we recognize that people are at different stages of their life and coming to understand the truth, and maybe coming off of a birth control pill and they are starting to use a condom instead. And, we're moving in the right direction. But that being said, there is a difference in the effectiveness of not having sex will guarantee that you will not have a baby.
Yes.
Having sex during a fertile time with a condom does not guarantee you will not have a baby.
Absolutely, very true.
Which is also
and that's
what I
an
heard you.
important point that most people don't recognize.
Right. And so maybe you can speak to just a little bit, if you have any understanding. I have very very low understanding of the research with condoms, but and their effectiveness rates. I always say, like, when I look at those studies, I find it frustrating because it's like not giving credit where credit is due. If you weren't fertile that day and you used a condom, you weren't going to get pregnant anyway. So you can't say that condom is effective. It's just your body wasn't fertile.
Right.
But really, we want to look at, okay, you use that condom during peak fertility. How likely are you to get fertile? But people aren't doing those studies, correct?
Yeah. Again, highlights so much more need for research, but a couple of really important points. So with some of the methods, particularly the mucus-only methods like the Billings ovulation method and the Creighton model, they very specifically exclude the use of condoms, on the one hand, because they want to promote abstinence, but also because the condom can actually interfere with the observations, right? Condoms can interfere with the sensation that a woman might experience. It can cause a discharge that could, or could affect the discharge. So she's not making accurate observations. So Billings and Creighton both clearly teach that if you're using the method for pregnancy prevention, you need to avoid sexual intercourse or genital contact during the fertile window. So use of the condom is technically, with those methods, incorrect use. And so there have not been studies of the Billings ovulation method or the Creighton model with condom usage, because that's not the way you use the method. The symptothermal studies, although symptothermal has been taught to use abstinence during the fertile window, the largest symptothermal study did ask women to track their use of condoms. And they did do what we call a subgroup analysis, looking at the effectiveness of the symptothermal method in couples that used condoms during the fertile time. And what they discovered was that there was not a significant difference in effectiveness. Like, the method was just as effective as if you abstained as if you used condoms. But what's important to note is when they actually looked at when women used the condoms during the fertile window, they actually used it on the edges of fertility. Maybe like the first day when they had a little bit of mucus, or, day 2 after their temperature rise. They weren't using it necessarily on the highest days of peak fertility. On the highest days of peak fertility, they still abstained. When it comes to the effectiveness of the condom, condoms are often quoted as being anywhere from 80 to 85% effective with typical use. However, as you noted, when you use a condom on a day when you're infertile, you're not going to get pregnant. But it's not because it was the condom that protected you from pregnancy. It's because you couldn't get pregnant on that day. So if we actually study the effectiveness of the condom during the fertile window only, especially on the days of higher fertility, you would expect that the unintended pregnancy rate might be even higher. And so unfortunately, the studies have not been done. So we don't know that for certain. But I see this a lot with women like, well, I just want to be sure I'm not going to get pregnant. So I'm going to use a condom. And I try to remind them, the condom is not perfect. It will not protect you from pregnancy. And in fact, I had a patient recently who was one of my infertility patients, actually. And we had treated her effectively for her underlying reproductive health issue. She had polycystic ovarian syndrome, and we had treated that. And after that, she was able to get pregnant, and she was very happy and thrilled and had her baby. And, the baby was 9 or 12 months age, and she decided to go back to, charting her cycle. And she and her husband were having sex, and they decided to have sex during the fertile window with a condom. 2 months later, came back pregnant. She's like, how did this happen? I was like, well, first off, condoms don't always work. And second off, again, she was so surprised because of her struggle with infertility. I'm like, we fixed your reproductive health issue. We treated your PCOS so your reproductive system was able to function the way it was designed to function. Now, she was happy about the pregnancy. It was unintended. It was unexpected. They weren't necessarily done with growing their family. But again, I think that's a perfect example of like, condoms do not always protect against pregnancy, which is why I hate the term protected intercourse. It's like, what are you protecting against, really? And it's not always going to be protective. It may reduce the likelihood of pregnancy, but to be sure you're going to be able to prevent pregnancy, especially if you have serious motivation, the most important thing is to avoid sexual relations, to abstain during that potential window of fertility, and not
Awesome. Thank you.
And you trust your own body.
Right. Thank you for going into that a little bit. I appreciate it. So, okay, as we wrap up here, that story actually touched a little bit on, Emily couldn't be here tonight because her little guy is sick, but she did want to ask, just kind of more like anecdotal, because you're so in this field and so immersed. She's had some questions from women who are coming to natural or fertility awareness-based methods, from non-faith based, for non-faith reasons, right? Just like motivated to use something in natural. If you're seeing, which I think the answer to this is yes, because it was yes when I was more immersed in the field. But just if you see those couple turning towards these more natural methods to avoid a pregnancy and to monitor their fertility as a whole.
Yeah, I see a huge number of women who are just so tired of the side effects of conventional forms of birth control. Women who are very concerned about the environment in which they live and the makeup products which they use and the food which they eat, and they, go organic because they don't want synthetic hormones. And then it hits them, but I'm taking a pill that's full of synthetic hormones. They're like, this doesn't make any sense. I'm like, you're right. It doesn't make any sense. So we are seeing so many more women who realize that they've been sold a false bill of goods by the medical system, saying that, to be equal to men, to truly have a fulfilling life, you need to shut down what makes you uniquely a woman. You need to shut down your reproductive system. And this has real implications for women. I mean, when women take hormonal birth control and shut down ovulation, they're not only preventing themselves potentially from getting pregnant, but they're limiting their body's exposure to the normal, natural, cyclical hormones that help them, right? I mean, estradiol is crucial for heart health. Progesterone does wonders for mental health and for bone health. And when we disrupt the normal hormonal cycle, we disrupt women's overall health. And women are starting to wake up to this fact. They're starting to realize this is not good for me health-wise. Sure, it might reduce my risk of pregnancy, but is there another way? Is there another way that I can learn to really, embrace my cycle, like live in sync with my cycle, recognize there are times in my cycle when I may have more energy, times in my cycle when I may, be more introverted, times in my cycle when it may be easier for me to exercise. There's so much we can learn, and women are starting to wake up to that reality and saying they want more. They want more information. I see it in the students that take our FACS elective. We just published a study where we looked at the students that took our elective, and over half of them I mean, actually, yeah, over half of them did not identify with any particular faith belief. I think less than 10% said they were taking the elective for faith-based reasons. Over 95% were taking it because they were interested in women's health. So we're seeing it in the medical and the health professionals units that we're training, but we're also seeing it among the general community. Women want this information. Women deserve this information. And unfortunately, I think the biggest rate limiting step to the widespread adoption of natural or fertility awareness-based methods is the lack of knowledge among the medical community and the discouragement from the doctors that many women encounter when they go see their physician.
Okay. What is the biggest NFP myth? What is the biggest NFP myth that you hear most frequently, or that you find yourself constantly debunking, or that just gets under your skin the most?
Great question. I think the most common myth that I hear, and the one that still makes me the most frustrated, is the fact that these methods, the NFP myth that I hear the most that makes me the most frustrated is the idea that these methods are not effective, when the reality is these methods can be very effective. And this myth is rooted in a statistic that has been quoted for decades now, that these methods, have almost a 25% failure rate. First of all, I hate the term failure, because if the outcome is a baby, I never like to label a baby as a failure right from the beginning. And the reality is the 25% unintended pregnancy rate is based on survey data from the late 90s and early 2000s, where they survey women who had gotten pregnant in the last year, and they asked them what method of family planning they were using. And what they do is they lump together all natural methods. And it's not the Billings method and the symptothermal method. It's, all various forms of like calendar calculations, many of which are not actual methods of fertility awareness. And so that is what I find most frustrating, because you can't lump them all together. The natural methods, although they're all natural, they work differently. Billings is different than symptothermal, which is different than Marquette. It's just like you can't lump together all progestin methods of birth control, like the Mirena IUD and the progestin mini pill, and lump together the effectiveness rates, because they all contain progestin. So that's, I think, the biggest myth is the effectiveness rate, when the research does show these methods, when used correctly, can be 86 to 98% effective with typical use. And that's what I combat primarily with the medical community.
Awesome. Well, thank you for all of your hard work, Marguerite, all the things you're doing with facts. Any good resources, anything specifically? Everything you mentioned today, I'll list in the show notes, but anything extra you'd like to leave with our listeners?
Yeah. So I just want to leave the idea, Labor Day is coming up. I know this will come out after Labor Day, but we kick off September with Labor Day, and that's all about work. And as a family physician, I take care of patients from cradle to grave. And oftentimes when I'm seeing young people, I'll ask them, what do you want to be when you grow up? And we talk about future careers and work. And most young people, if they're thinking about a career, they are starting to plan like, if I want to be a teacher, I need to go to college, and then I'm going to need to student teach. And they start to plan for their life, right? At least for their career. But what we don't teach young people is to plan for their reproductive life. And so I try and do this with my patients. I'll ask young people not only like, what do you want to be when you grow up, but like, what do you want your family to look like when you grow up? Do you want to have children? How many children do you want to have? And if, based on that information, help them to think through, like, when you're planning for your reproductive life, you need to take those steps now to make sure that you can achieve those goals. And so I'm excited that in a few weeks, we'll be doing a conference on September 19th in Philadelphia. It's an in-person conference. It's open to everyone. And we're kicking that conference off with a presentation called Reproductive Life Planning, which should be all about helping young people think about not only their future lives in terms of their career, but their future lives in terms of their family, and the steps that they can take now to make it possible for them to have the family that they envision. I want that to become a reality, because right now my reality is taking care of women in their 40s who have waited too long and who are desperately trying to have that child that they thought was always there, but that dream is now eluding them. So our focus is on educating on the importance of reproductive life planning. And then at our virtual conference in October, really addressing those issues that can affect your ability to have children. The common causes of infertility, like irregular cycles due to PCOS and painful periods due to endometriosis, and as well as looking at recurrent miscarriage. October is Pregnancy and Infant Loss Awareness Month, and we're excited to have Dr. Phil Boyle speaking on the topic of recurrent miscarriage at our virtual conference. So I encourage your listeners to learn more, visit our FACS website, connect with your medical colleagues, and encourage them to check out FACS and to attend any of our upcoming conferences, whether it's in person or our online conference, as well as all of our webinars and CME course content. So thanks, Amy Lynn, for helping me share the facts about fertility with your audience.
Thank you so much, Dr. Duane. I really appreciate it. All right, guys, I'll list everything in the show notes. And hopefully we'll get to have you back. Good luck with all the conferences, and I'll talk to you soon.
Sounds
Bye.
great. Bye.
That wraps up another episode of the NFP Podcast. Thank you so much for joining us today. We hope you found our discussion enlightening and empowering. Don't forget to subscribe so you never miss an episode. We'd love to hear from you. Please connect with us by sending us an email with your questions and stories to thenfpshow@gmail.com. We'll be back next week with more insights, tips, and heartfelt conversations about natural family planning. Until then, love responsibly.